Welcome back. We are here for, I think, the last session of the meeting, I believe. We have 2 more live cases. They are busy in Asan Medical Center, I think, here. And then just some final closing remarks. So without further ado, I'm David Cohen from New York City, and my co-moderator is Dr. Hong from Seoul, and we have a very dedicated panel who are here right to the very end. So let's go to Asan Medical Center and to Dr. An and Dr. Kang. Hello, hi Jung-Min.
Hi, David. So good afternoon. It must be the last live demonstration. We prepared the 2 cases. My case is a very high risk TAVR procedure. So I'd like to introduce you already knew well the Dr. Kang and our senior fellow Dr. Jo. Dr. Jo will introduce the patient history.
Thank you. 64-year-old male was admitted for dyspnea on exertion. He had a history of PCI at OM and distal RCA at other hospital. Before TAVR procedure, PCI was already done at mid-LAD, OM, mid-distal RCA. The echocardiography showed severe degenerative aortic stenosis and decreased LV systolic function. His past medical history is hemodialysis due to ADPKD ESRD. Next. His STS score was high and 11.372%. Next. Electrocardiogram shows LVH picture and sinus rhythm. Next. Chest X-ray shows no specific findings. Next. Professor San.
This is a typical clinical case with classical low flow, low gradient AES. The first problem in diagnosis of this case is the discrepancy between aortic valve area and pressure gradient. Valve area of 0.6 is compatible with severe aortic stenosis, but mean pressure gradient of 28 is insufficient. Also, this patient had very depressed LV function of ejection fraction of 21%, resulted in stroke volume index of 27. In general, we define the stroke volume index below 35 or lower is low flow stages. Also, this patient had moderate functional MR and severe functional PR and decreased RV function. The other non-invasive tests show non-specific finding. Next slide. The echocardiographic image shows very enlarged LV with decreased LV ejection fraction. The aortic valve showed advanced thickening and restricted motion. The global LV ejection fraction is 21%. That was thought to be number 1 cause of decreased flow stages. But also, this patient had functional MR and TR with RV function. Those were reasonable causes of low flow stages. Next slide. In this situation, for definitive diagnosis, we performed the abdominal stress echocardiography. There were 2 points. One point was to measurement of Doppler parameters during dopamine infusion with increased flow rate. And the second point is to determine the presence of contractile reserve. Our patient showed basal stroke volume of 45 milliliter, which was increased to 65 during dopamine infusion. In general, we define the increase of stroke volume by 20% of baseline is the presence of contractile reserve. So our patient showed good contractile reserve, and all the Doppler parameters were compatible with severe aortic stenosis. So this symptomatic patient with classical low flow, low gradient AES and had contractile reserve was compatible with class 1 indication of aortic valve replacement in current European guideline. Okay.
Thank you, Dr. Son.
And its initial coronary angiogram before TAVR shows 3 vessel disease. Next. We rated on PCI at mid-RCA and OM and mid-LAD using 4 stents. Next. It's aortic annulus view. Annulus short diameter was 24.8 millimeter and long diameter was 29.0 millimeter. Annulus area was 545 square millimeter. Next, it's another view to the sinus of Valsalva and ST junction. Sinus of Valsalva to annulus area ratio was 1.85 and ST junction to annulus area ratio was 1.47. Next, it's LVOT. LVOT shows no calcification and LVOT to annulus area ratio was 1.07. Next, it's a calcium distribution. Calcium distribution show NCC has 226 cubic millimeter and total of calcium amount was 481 cubic millimeter. It's a moderate amount. Next, it's another calcium view. Aortic calcium shows in this view. Next, it's a coronary height. Coronary height was enough to TAVR 80 millimeter. Both. Next, iliofemoral arteries shows wide enough to femoral approach, so we choose right femoral approach. Next, it's a sizing table for SAPIEN 3. Next, it's the sizing table for Evolut. We choose 34 size and perimeter oversize was 127. Next, it's an annulus coplanar projection view. Next, it's our TAVR planning. TAVR planning Evolut Pro 34 millimeter size via right femoral. And so.
Yeah, thank you, Dr. Joe. It's actually a very complex patient, high risk patient, low ejection fraction, confirmed by the time stress echo, severe AS. So, do you have any comment, any advice?
Okay. Regard whatever the TAVR technique, anyhow, this is a real very high risk patient. It's a high risk of arrest during a procedure. The reason why, first of all, the low LV function and the combined disease. What I mean is even though you have a revascularized coronary artery, but the functional MR or functional TR, and even though you have the dopamine stress echo test is correct, the ejection fraction was improved, but when we look at the echocardiogram, we will check the wall thickness. It is so different from the other type of the patient. Usually, severe aortic patient, aortic valve, severe aortic stenosis patient, wall is very thickened. But this patient is thinning. It means that the recovery of LV function might be some suspicious. Anyhow, did you prepare the ECMO on site?
Oh, not
then,
on site, but
and the preparation, and
surgeon is ready.
and then start the TAVR procedure.
The Jung-Min, it's David Cohen. I'm interested in your choice of the valve. I think it's you have a difficult choice because you want to preserve good coronary access, given how complex the coronary disease is and his end-stage renal disease. The chance that he's going to not need more PCI in his life is very small. Yet, I guess your interest in not doing rapid pacing perhaps was your predominant choice. Can you talk us about that a little bit?
Yeah, we discussed a lot about which valve would be better for this patient. So yes, you are correct. Considering the coronary access, the balloon expandable valve would be better. But today we just focus on the today procedure, not future. So to maintain the hemodynamics during the procedure, so we'd like to select the self-expandable device rather than balloon expandable device.
Does everybody agree with that approach? Anybody want to have a different strategy?
Yes, I think for device choices, is actually there are different aspects. This patient could have a crash, for example, during the pacing or during the deployment. At some point, there may be jamming of the hemodynamics, or there may be conduction abnormalities afterwards that make the synchronized pacing or heart blocks would make the heart function worse. So overall, I don't think it would be a definite answer to say which valve is superior. I usually would say the valve that you're more familiar with, and while the anatomy allows, you should put that in with all the backups like Impeller or Atmo in our center.
Personally, I think I'd like if you use the Evolute, please the one shot, one kill. What I mean is that the depth is maybe deeper, just deploy it. You know, if we think about the long-term outcome of this patient, maybe, but the immediate outcome, survival is more important. Anyhow, just discharge of the patient, after the TAVR discharge of it, you win.
Regarding the hemodynamics, the SAPIEN system is, of course, has some weak point in terms of the rapid pacing, but it also has a strong point in terms of the procedural time. So in this case, we need to shorten the procedural time. So in terms of that, SAPIEN valve is also a good choice.
I think that I absolutely agree with you, Dr. Han. Left pacing time that should be short. It's very important because during left pacing, cardiac arrest may be possible. So if you have a short left pacing, I think that the SAPIEN valve is much better than the Evolute self-expandable valve. Valve deploying time very short, as you know that.
When you close the wire across the aortic valve is a little bit the horizontal. It means that the manipulation might be easier, but please very short period of the TAVR valve deployment.
Yeah, I think it's everyone has probably done a case or two where a rapid pacing run, and then the patient needed to be, get CPR or something afterwards. So it's always a little bit nerve-wracking to do a case when the patient is compromised.
Yeah, one thing I would add is that you probably should optimize hemodynamic as much as possible, meaning the LVEDP at the time of a TAVR procedure shouldn't be very high.
Okay, during a TAVR procedure, please show us the hemodynamic, not the slide.
You skipped that part.
They already passed that.
I mean, sometimes we would put this patient on dobutamine before 5 milligrams or micrograms. Sorry.
Now we are infusing the dobutamine already.
You have started already?
Yeah.
And this is a 34.
34.
Evolute, right? Evolute R?
Yeah.
Or,
Yeah, right.
Plus? You have the plus?
Just under the conscious sedation, this procedure.
Yes, cautious. Yes.
What kinds of drug do you use for conscious sedation? Because some kind of drug drop blood pressure especially in severe LV systolic disease.
Before introduce the caster, please alignment. You need the axis is some different. You make the rotate and please parallel to the pigtail.
And we are infusing
If you
dexmedetomidine.
insert the caster, it might cause some compromise of the hemodynamics. So before insert the caster, please. Now it's time to the line. More.
You're looking at the hat.
Oh, not easy. Yeah, not easy to rotate.
Okay.
Sometimes you can rotate it in the descending aorta before you come up.
That is one of the scenario. What I mean is that when you there is the axis is different, and then deploy that, and you find some of the is depth, the more deeper, and then pull back again, and try second episode. There is the next chance is arrest.
Yeah. So I'm relieving. Test. Stop. Test. Okay. Good.
Okay.
Are you in the
Test.
cusp overlap view
Stop.
now?
Yes, we are in the cusp of review. Test. Stop.
Okay.
Relieving.
Slowly.
Stop.
Slowly.
Test. Okay. Relieving.
Hold it.
올라가라.
Hold it. Okay. So far, so. Okay. More faster.
더.
Oh.
Stop.
Okay. Test it.
Push it back.
Yeah. Test.
Okay.
I think it's good.
It's good. It's ready. It's good.
Yeah.
You go to the
Please.
three cusp now, or you just deploy?
I would go to
Three cusp. That's good. Yeah, just to check.
3 cusp view,
Pay
please.
attention to the not pop up.
Yeah.
Looks good.
So he's doing it without any pacing,
Little.
Yeah, no pacing. Yeah.
no predilatation, no pacing whatsoever.
Test.
Look like a pretty good position.
Okay.
Watch out.
Slow.
Slowly.
Slow.
More
Okay,
slowly.
Slow. Just a moment.
Okay.
Okay.
Slow.
좀더 뺍니다.
Very careful.
Watch out the nose cone.
Yeah. 자, 나가자. 테스트.
Okay.
very nice.
Excellent. Slowly.
와이어 잡고.
잡고 있습니다.
We actually pull the wire in. Pull the wire completely in.
Slowly.
Beautiful.
Excellent.
Looking good.
Personally, this is actually not the live demonstration cases. It's a really high risk of the patient.
That's
Asan, you are wonderful.
it's a very, impressive to get it in that good of a position without any pacing.
Without going in and out.
No, very well done. I think the patient's heart will like this.
Sometimes the movement of a valve is just so severe that I'd like to do some low pacing, but usually I'm not a big fan of pacing during the implantation.
Beautiful.
Okay.
And I think this is, we always used to get nervous about doing these cases conscious, but I think that, all of the anesthetic agents we give are negative inotropes, and they lower the blood pressure and makes everything more difficult. So I think this is the kind of case where it really is beneficial to do it with the patient
Ready?
as close to awake as possible. Looks good.
Okay.
I don't think I see any
Okay.
AR.
Some AR, but I don't care.
Do you measure the final hemodynamics, or you have an echo?
Yes. Could
You
show
already
us
did
the
a good
echo,
job.
please? Yeah.
Really good job. Best job.
So, not perfectly round, but I think it's acceptable. So I'd like to change the wire to the pigtail. Dr. Son, our echo specialist, is now examining the patient echo.
Oh, great. Is he doing the echo? We don't see the screen for the echo yet. There we go.
Can you please show the echo? Yeah.
아까보다 좀 뛰는 것 같다.
Contractility looks better than before.
Just a tiny bit of central AI. Maybe that's from your wire.
Yeah, yeah. Why?
Because this procedure is a high-risk patient, so I did not ask the more detail. Patient age is 64.
Color.
End-stage renal
Yes,
disease.
right, 64. Yeah.
That makes you 84. I think
Okay.
looks very, very, very good. You should be happy man, Jung-Min.
Is there any comment from the echocardiographer? Please tell us.
Yeah, the valve is very stable and shows no significant AR after procedure.
If it is available, or what about the moderate MR? Before the TAVR, it was presented in the moderate. Is similar? And the severe
Did you check
TR.
the MR and TR?
Yeah, I'll check that.
Blood pressure became higher after the procedure.
TR doesn't very often get better with
Yeah.
TAVR or with mitral. Still see some MR there.
Still,
You have to stop
the
the
severe degree of
inotropic
mitral
first.
regurgitation
That's true.
shows as mild to moderate, but
Okay. How about the TR?
Doesn't look too bad, but maybe the windows aren't great.
Because the
Yeah, even
procedure
though
was
very
so
special-
successfully done, if the mind is more comfortable, we have a more
the
discussion
TR grade
about
is mild.
in the more comfortable situation. Okay,
It's,
Dr. Han,
mild
what
TR.
will you do?
So the measure the pressure gradient, and then if no pressure gradient, pressure curve looks good. So I'd like to finish the procedure.
Okay.
No, I think this is and this is what TAVR was originally invented for. These kind of patients who are too sick for anything else. Now they're the minority that we treat, but still is a very good treatment for these kind of patients.
So this patient may have a very high surgical risk if a patient to have the open heart surgery.
I think these are always very challenging patients because the data for doing TAVR in dialysis patients is not great, but the data for not doing TAVR in dialysis patients is worse. So I think that's the challenge. We aren't so much trying to make them live for 5 or 10 years. We're trying to help them feel better. Is our primary goal.
Can you see the pressure curve?
We do.
On
We
the
see one
screen?
pressure. There we go.
Okay.
Okay, excellent.
LVEDP is a little bit high, but the AR index it looks very nice and no pressure gradient. So I'd like to stop my procedure.
Excellent.
I think anybody want to do anything more? I think we are all very happy with the results you have, and for really giving us a beautiful demonstration of how a self-expanding valve, when done expertly, can really give a great result with minimal hemodynamic perturbation. So I think that's really the message here.
안정민 선생님 진짜 멋있었다. 잘했다 좀.
아유 감사합니다, 선생님.
Okay, very nice result. We will move the next last demonstration.
Yeah.
Let's say back.
Thank you.
Thank you.
Ready?
Dr. Park.
Okay, can you hear us?
Yes.
Okay,
Alright.
so this case is our finale case, and compared to the previous one, relatively simple. So for finalization of this year meeting, okay, Professor S.J. Park and Dr. Kim. Okay, we're gonna start the patient briefings. Okay.
Yeah, thank you for introduction. Today, our patient, the 75-year-old female, was admitted for dyspnea, near class 2. The patient underlying disease have hypertension and diabetes, and echocardiography showed the severe AS. There's no past medical history. Next. And you can see the diabetes and hypertension with the STS score. It's a 2.32 with a low-risk patient. Next. EKG showed the normal sinus rhythm with the LVH patterns. Next. Chest radiograph showed no cardiomegaly and no pulmonary edema. Next. The TT showed the very severe AS, and you can see the flow acceleration at the AV level, and AVA is 0.4, and for velocity, maximum velocity is 5.7. Next. We do the CT analysis for TAVR, and the annulus area is 403, and long diameter is 26, and short diameter is 19. Next. The sinus valve ratio is 1.68, and STJ ratio is 1.73. It's relatively small. And next. The LVAT show and no calcification with the ratio of the 0.94. Next. The calcium have amount is 1,100, about the mainly distribute at the NCC and LCC. Next, the whole aorta is calcification is moderate calcification at the abdominal aorta. Next, coronary height is left side is 12.3 millimeter and RCA is 17.37 millimeter. Next. Both femoral is feasible to transfemoral TAVR. Next. So this is sizing chart. If we choose the Sapien 3, maybe 23 millimeter valve is appropriate. And next, if we choose the Evolute, and maybe 26 millimeter valve is appropriate. Next, this is Copeland view. Next, this is our initial planning of TAVR.
Okay, it's almost there. So thank you for joining us, and even in the bad situation, right? This is our last. Okay, would you show the table for sizing? Actually, we're gonna do the balloon expanders then, right? We're gonna discuss it later. So, point is actually very simple in terms of oversize wise. Would you show us calcium amount just before? Okay, more than 1,000. So we define a little bit heavy calcification for particularly these patients. Between the 400 and 1,000, maybe a moderate calcification. So would you show us again table for that? Oh, table. So sizing table.
Sizing table.
Okay, coronary height is good. sinus valsalva relatively small, ratio is small, however, still bigger than the anyways annulus concern. And so very simply, just depending on the calcium amount, it's high calcium, so you wanna do the oversizing rate is almost less than 5%, almost 0% here, right?
Yes.
So if we choose the balloon expandable for particular this patient, it's quite good condition. Calcium amount very heavy one, and so we choose the 23. Oversize wise percent, just 1% is almost nominal, you know, size wise. So we just the reason why you want to choose the 23.
Okay.
And then we have to consider, you know, calcium locations and sinus valsalva is how much big and coronary height is how, you know, is appropriate or not. And so that's the point. So lots of evaluation, but finally we're going to decide just the 23 nominal, right?
Right.
So I want to really talk about this decision making, how to select the device size. Okay, so Duk-Woo,
Okay.
why don't you come
Okay.
by?
So-
Join us together.
So
we
the-
are the
So
All right.
Okay, go
SJ,
ahead.
DW, it's David Cohen. So with this degree of calcification, if this was a self-expanding, I think we would predilate. Are you thinking to predilate this with the heavy calcification, or?
Yeah, yes. And so we do, so not to, you know, exactly, we don't have a cutoff value to do predilation or not. However, maybe 600 more than that calcium amount, we do the predilation, right? And lastly, we discussed that it's relatively small. So, you know, we don't use too much big, you know, balloon. Just
So what size will you use?
And we're
What
gonna
size?
use 18.
Okay.
Yes, two sizing down, and this is a GMAD balloon.
Everybody on the
So,
panel agree with predilating? Everybody like that idea? Lots of nodding. Okay.
all right.
So, and if the severe calcium was combined, sometimes the valve passage is nearly not feasible. Sometimes not safe.
I think it's nice also with the the valve area is 0.4, so it's a very tight valve.
잡아.
Yeah.
잘
So you,
잡아.
Was crossing it all difficult or not too bad?
all right. It's very easy to
Yes.
cross. Draw, and
자,
keep.
오케이, 밟으시고 페이싱 온
All
하겠습니다.
right.
오케이.
Ready?
자, 페이싱 온.
Facing on. Inflate. Fasting. All right. I like it.
오케이, 디플릿.
Inflate.
오케이, 페이싱 오프.
I don't want to back and forth balloon movement, and so relatively fast inflation during
Yes.
the predilation.
You always do an
we-
injection with predilation, SJ?
Yes.
Or DW?
Okay, yeah, we're gonna show us, and we apply
Alright.
the 18. Could you show us the previous angel? So, and that was the calcium chunk. This is 18, and after the implantations, the
Alright.
coronary shows the, the aortogram coronary ostium would be okay, and the valve area was expanded well.
Yeah.
Okay.
Okay. We prepare 23
Yep.
nominal.
Yes.
You see one piece of the calcium
something
going
like
towards the
that
left
here.
coronary, but not that
Right.
far.
All right.
1, 2, 3. 1, 2, 3.
Not too much difficult to
Okay.
pass the device smoothly.
Okay.
Do you overfill the balloon?
Or
So, and we apply the, we apply the 18 pre-balloon, and then this is the 23 is nominal. That means just 0% of overdilation.
oh,
Okay.
very simple, heavy calcifications,
Okay,
more than
and then-
1,000 something. So the ratio of oversizing is almost a zero nominal.
Okay.
Very simple. And then we have to consider
Yes.
that there are issues here, right?
Okay.
Doing the type of procedures, if you got some ideas, it's not too much difficult, I think so. All right, let's push it in. All right, some
Okay,
difficulties. Okay.
Hope front of you.
To
Okay, slightly,
pull the pressure,
yeah, slightly
Okay.
pull the pusher.
push in a little bit further.
Okay. Okay, slightly pull back.
Okay, good.
And then over here, you can.
All right, here
Okay,
we are.
good. Test
Very
it.
much coaxials, is very
Test
good
it.
condition. Test, please.
Okay,
All
I
right,
think the
a little
position
bit.
is good.
This morning we have discussed about a little bit high position of the
Okay,
device.
good.
However, I think it's good.
Yes,
test,
test it.
please.
Okay, good. Excellent.
All right.
Okay.
Sorry, pacing,
Facing.
contrast.
Contrast.
Why
Okay,
not?
inflate. 쭉. 1, 2, 3, 4, 5.
Okay.
Deflate. 기다려.
Facing
플로로.
up.
자, facing off. Okay.
All right.
3, 3. Okay, here, and we're gonna check it out immediately.
Wire, a little bit wire.
Yeah,
off,
slightly
please.
pull back
Okay,
the
good.
wire.
Pull
Okay,
a little
good.
bit further.
한번 에코 한번 봐보세요.
Okay.
오케이, 플로로. 네.
All right, we don't do too much discussion. All right, just I want to show that how to select the device size-wise is I would like to simplify it.
Yes.
Mild, maybe 10 to 15%. As ultra, in case of ultra, we have a little bit lower, level of, oversizing ratios. However, in case of moderate, heavy calcium, why not just a nominal? If there are some PBL, moderate to severe, so we want to do a little bit high, volume inflate at 1 cc or 2 cc more. That is our strategy for the safety concern.
Okay,
All right.
this is a 5-chamber view.
All right, so we want to do
Okay, mild, and so we will check it out the
L2랑
L2랑, and then we will measure. 이거 한번 맞춰봐봐. 잠깐만요, 선생님. 조금 이거 뷰를
Okay,
보게.
perfect.
잠깐만요, 조금.
너무 okay, good.
오케이, 끝. 플로로. 이 정도 됐지? 자, 이제 ready. 풀샷. Good. So
fantastic.
I think it's expanded well. We can
What do you
remove
think?
the.
Dr. Hong,
Excellent.
Yeah, 1 millimeter
Do we need-
depth, no trace AI maybe.
Are you intentionally target the low margin of the valve? Are you already
right,
know that?
position-wise is good.
With all the calcium, I think it's gonna,
Too much accurate.
it won't go anywhere.
Yeah, too much accurate.
All right.
한번 리무버해서 자 보면서 자 1, 2, 3, 1,
Alright,
2, 3, 1, 2, 3.
Didn't do, second inflation for that. Let's see.
Okay.
Okay.
So
Alright,
I have
after-
one question, and David and Professor Hong, and
Come
the cath lab. Do you prefer the high implantation strategy even in the Sapien?
I mean, I think it's we don't want to give the patient a left bundle. There's even a pacemaker is not necessarily the same as a left bundle. We've been doing some work with the TVT registry, and a transient left bundle at the end of the procedure is worse than a pacemaker. And so I think that's what we really want to avoid here. And so I think, this may be 1 millimeter higher than I would like, but not, I think this is a terrific result. It does extend up to the coronaries on the left coronary because I think the height was 12, and this is about 18 millimeters tall, the valve frame now. But I think it will be fine. Does anybody want to take this out and put it in lower now?
So I think the hemodynamics is monogram that shows there is no pressure gradient. AR index approximately 30, and the result is excellent.
Is
So,
a different. We did not see.
We didn't see the pressure.
LV pressure.
Okay, can you show us?
Only the aortic pressure.
Pressure. in the screen?
Okay,
Why not?
okay.
Okay, good.
Oh, beautiful.
Yes, result is good, and there is no pressure gradient. And here, we're gonna
Okay, why not?
check it up
One
the
of the
final aortogram.
Not only.
Okay. 오케이, 됐어요? 자, 준비됐지? 입니다. 자, 풀샷. Good. I think it's a mild AR. And concept
All
view.
right. How
오케이, 됐다. 오케이, enjoy.
some degree of a PBL?
Good.
Very little.
Oh, I like this view, right? You cannot see that, right? What's happening?
Yeah, so I think this is the last finale case, and
Previous
yeah,
one,
we
please.
did the final result is acceptable, and the severe calcium we applied the Sapien 3 Ultra is a 23 is nominal, so and this is our final result.
Angiographic definition of a PBL, what is it?
Mild, yes.
Mild.
Yeah.
Maybe we use the Sapien Ultra, right? Getting better. I believe so. However, we didn't do the echocardiogram in the later. So we just okay. This is the last cases. I want to show some more. How can I say that? Our teamwork and some more, doing the easier. Yeah. We got some ideas, so I would like to really focus, emphasize the pre-evaluation, echo evaluation, CT evaluation. We got some ideas. Doing the procedure itself is not too much difficult, right? So, anyway, this is final cases. So,
Okay, so and our team is really appreciate all the moderator and all panel is our long-standing friend, and the real contribution absolutely the essential part of the success of the AP valve structure heart meeting. So next year we would be available different type of TAVR device, Accurate Neo 2 and Navito would be available at the time of the next year AP valve meeting. Also, we would like to show the tricuspid, the clip would be available. We're gonna show some different type of the valve, and thank you all the audience and the panel and the moderator, and really appreciate the support for our meeting.
Good.
Thank you so much.
Right? Thank you.
See you next year. Thank you.
Well, I think it's been a wonderful meeting. It's some fantastic educational cases, finishing up with a simple but elegant case. And I want to thank everyone for coming, all of the panelists, all of the faculty, all of the participants, all of the sponsors. It's really been a terrific meeting. I hope everybody gets home safe and dry.